Hello and welcome back to our series on common ENT presentations that you may see during your emergency clinics or on call. Today we're going to be discussing otitis externa, otherwise known as infection of the external auditory canal or outer ear. So things that you'll need in assessing these patients are an otoscope with a speculum, oral suction tips, a Pope wick, and swabs available for cultures. Patients with otitis externa present with ear pain and discharge and may often have hearing loss as well. When taking a history, you'll want to be aware of certain risk factors such as swimmers, people that wash their hair daily, any use of cotton buds or other foreign bodies to the ear canal. Any background of diabetes mellitus is a risk factor for necrotizing otitis externa. Any use of hearing aids and any history of psoriasis, eczema, or other skin conditions around the ear. You want to remember to ask about any previous infections of the ear and any treatments that they've been on before, any previous surgeries, both recently and in the past, any previous radiotherapy to the head or neck, and any other comorbidities. When looking at patients with otitis externa, they can often present with discharge as well as stenosis of the ear canal. You'll want to also remember to examine any and all head and neck lymph nodes, as well as the facial nerve and the skin around the external ear as well. Some patients may have visible discharge on external examination of the ear. Be sure to suction this away before continuing on with any examination with the otoscope or microscope. Red flags that you'll need to look out for include any symptoms of unremitting pain, any signs of systemic illness, any granulation tissue or bone erosions that you can see on the examination of the ear canal, any patients that develop any new facial nerve palsy, any complete stenosis of the ear canal, and any cellulitis of the pinna or the periauricular area. In patients with any of these red flags, we advise that you admit them and discuss with the on-call registrar. Some patients, especially those with a background of diabetes, are at risk of developing necrotizing otitis externa. These present with symptoms as mentioned in the red flags section, and it is a serious condition with a high associated morbidity and mortality. This is because the infection can rapidly spread from the external auditory meatus and can involve the surrounding soft tissue and the adjacent neck spaces and skull space and can spread to more vital areas. If you suspect this, admit the patient and be sure to involve a senior early. In all patients with otitis externa, you want to take swabs for cultures and arrange for biopsy of any granulation tissue if present. Mild cases of acute otitis externa are best managed with topical antibiotics. So in this trust we use either Silodex or Sofradex, depending on whether or not there is any suspicion of perforation of the eardrum. If there's a risk of malignant otitis externa, as mentioned before, then you'll need to admit this patient and start them on IV antibiotics. Make sure that you take swabs, as these patients will need to be discussed with microbiology further down the line. In patients that develop ear canal stenosis, these are often better managed with the insertion of a Pope wick. This will help keep the canal open and can allow topical antibiotics that soak the Pope wick to reach the infected areas. A lot of patients find Pope wicks somewhat uncomfortable, so just advise that they may feel some pressure or pain in the ear, but this will help improve their symptoms faster. Advise all patients with otitis externa to keep their ear clean and dry. When showering, use cotton balls with Vaseline to prevent any water from entering the ear canal. If you see the patient during the day, it's advisable to see them back in the emergency ENT clinic, as microsuctioning will be beneficial for removing any discharge in the ear canal. In arranging follow-up for these patients, you'll want to optimize any risk factors. So in diabetic patients, you want to make sure that their control is up to speed. Patients that are discharged home with severe otitis externa will often need follow-up in the emergency clinic for repeat microsuctioning within 7 to 10 days. And if they've had a Pope wick inserted, this will have to be removed within 48 to 72 hours. Thank you. That concludes our talk on otitis externa.